is as equal important as STIMI itself. So let's start with these high-risk ECGs, which I think everybody should have at least an idea about it. This will help identification of more and more patients at risk. So what's classic STIMI ECG? STIMI, as we all know, is ST elevation in the ECG in two contiguous leads, two or more small squares. So you can see here that there is ST elevation here above the baseline, and this is in lead 1 and AVL. This indicates myocardial infarction or necrosis in this area of the myocardium, which is reflected in the lateral leads. Usually there is reciprocal ST changes or ST depression in the opposite lead. So suppose there is 1 and AVL ST elevation in lateral, I mean, you will have inferior ST depression like here. It is not a must, but finding these reciprocal changes will make the diagnosis more solid and will omit many of the differential diagnosis of ST elevation. So it has to be on 2 or more leads and 2 or more millimeters. In all leads, 1 millimeter or more, except in V2, V3, you will have 2 millimeter as a median. But if below 40 years, up to 2.5 millimeter, and in all ages above 1.5 millimeter. But in all other leads, more than 1 millimeter in 2 contiguous leads is enough. So this is a classic example of inferior STIMI. You can see here lead 2, lead 3, and the AVF. There is ST elevation, ST elevation, ST elevation, together with ST depression here in 1 and AVL. This is lateral leads. So as you can see, we are looking at certain territory. So if you are looking at inferior, usually we take lead 2, lead 3, and the AVF together. Then we look at the 1 and the AVL together, then septal leads together, lateral leads also together to get an idea about territories. So here you can see ST elevation here, more than 1 millimeter. Here also ST elevation more than 1 millimeter. Here more than 1 millimeter. This is reciprocal depression. Then now you are done. This is a classic STIMI, which mandates either thrombolysis or activation of cath lab for PCR. Let's take another example. Here also, there is inferior STIMI, lead 2, lead 3, lead AVF. There is very big elevation in the 3 leads. Also, you have here lateral reciprocal or ST depression. This ECG also is showing one more sign here that there is ST depression plus positive R wave in septal leads. This indicates posterior STIMI also. So this is inferior and also indicate posterior STIMI. This will be confirmed by posterior leads. So usually inferior STIMI, either it will be alone, inferior alone, or it can have some posterior extension or RV involvement, which will show in right leads or posterior leads. So once you find inferior STIMI, you should do also right leads and posterior leads to check if any associated posterior or RV involvement. So again, STIMI itself will not come with the classic ST elevation all of a sudden. It will go through stages. It's also important to know these stages or the evolution of STIMI so that you can pick up the diagnosis in any of these stages and you can follow the progress. So it will start from normal morphology, then hyperacute T wave, then ST elevation, and the R wave becomes small. Then you have Q wave, T wave inversion, then ST will resolve, Q wave will persist, T wave is still inverted, then T wave normalize, Q wave persist, and ST normalize. So it will start from normal ECG until you have only Q waves. So Q wave indicates evolved STIMI, and normal morphology indicates very early presentation. So some large amount of patient also can present very early with normal ECG with persistent chest pain. You have to do serial ECG to detect which stage the patient is in and to pick earlier as possible the ST elevation. Here again, the evolution of STEMI in non-perfused or sometimes in perfused patient, but not complete reperfusion like thrombolysis or so. So normal ECG, peak T wave, and ST elevation start to rise. Then there is some Q waves and T waves, and ST normalize, leaving only Q wave as a scar or indication of old MI. Here again, the same concept. Okay, let's have a quick look at what is a STEMI equivalent. So STEMI, we have explained what is STEMI, and it is the most classic and the most dangerous pattern in the ECG. But now we are talking about STEMI equivalent, which represent also a large group of patients. So STEMI equivalent are those patients which do not present with the classic ECG of STEMI. However, they have high likelihood of acute coronary occlusion. They can easily be missed and thus associated with poor outcome. They benefit from early intervention. However, currently not all of these patterns are endorsed by the guidelines as STEMI equivalent yet. However, clinical practice worldwide supports the use of early intervention in such cases, and this may be reflected in the guidelines in the near future. So we'll summarize here. First is Wellen syndrome, second is Winter syndrome, third is ST elevation in AVR, then left bundle and Cigarposa criteria, isolated posterior MI. There are also some rare scenarios that we are not going to discuss here, like Eslam Rashid syndrome and others, but maybe later on we'll have a quick note on them. So Wellen syndrome or Widowmaker. This was first described by Hein and Wellen and colleagues in 1982 in a subgroup of people with unstable angina. The presence of Wellen syndrome carries significant diagnostic and prognostic value. All people in the DZ1 study with characteristic findings had more than 50% stenosis of the left anterior descending artery, like 80% stenosis with complete or near complete occlusion, like around 59%. So Wellen sign has also been seen as a rare presentation of Takotsubo cardiomyopathy and or stress cardiomyopathy. So how we diagnose Wellen syndrome? First thing is a history of intermittent chest pain. So the patient should have chest pain, not continuous, but at least it is coming and going, typical angina chest pain. During the episodes of chest pain, ECG may show normal or mild ST changes, either elevation or depression. However, normal or mildly elevated cardiac enzymes. And here is the trick that this patient, at some time, he will present in between the attacks with normal ECG, normal cardiac enzymes. But this pattern in ECG will show not all the time, but it will show at some time. So it's important once you detect this pattern that you take it seriously and admit the patient for coronary angina. So what is this pattern? It is deeply inverted or biphasic T wave in V2 and V3. This can possibly extend to V1 or V4, V5, or even V6 when pain-free. So the main diagnostic criteria should be in V2 and V3. Maybe it will extend proximal or distal to V1 or V4, V5, V6, but it has to be here in V2 and V3. So either deep T wave or biphasic T wave. So you can see here, there are two types or two forms, type A, type B. There is deep T wave and there is biphasic T wave which is upward than downward. Both patterns are identified as Willen ECG changes or Willen sign or LED T wave syndrome. So this is specific for critical stenosis of proximal LED with high rate of becoming acute anterior wall MI, less than 1 week. This is called Widowmaker because the LED is supplying the whole left ventricle. So once this artery is occluded, this means in most of cases sudden death. So typically with history of angina, but T-wave changes often occur during a period without chest pain as a result from myocardial reperfusion. Serial ECGs in this patient is critical. This is also another concept that any patient with persistent chest pain should have serial ECG. Even if the first ECG look normal, it doesn't mean there is no ischemia or it doesn't exclude myocardial ischemia. You have to look carefully on serial ECGs to detect any abnormality and any specific pattern like Willen sign, which will mandate that this patient will have angio as soon as possible. So cardiac enzymes, normal or slightly elevated. T-wave changes often during pain-free period. As we said, this indicates reperfusion rather than occlusion here. So there is like little occlusion and opening, there is reperfusion, and this sign is showing that there is some critical lesion which is about to close. ST elevation is none or minimal. This is here the trick, that this is not STIMI. However, it should be managed as STIMI is about to happen. Reciprocal R wave progression is not. So management, urgent coronary angiography based on the acute coronary syndrome protocol with full anti-ischemics monitor or CCU or something. Do not stress this patient. This can be fatal. So Willen syndrome, if you identified also in a patient who was sent to you for a stress test, you should not do the stress test. Patient should go directly for coronary angiography. It is very dangerous to stress this patient also. So again, you will find there is some debate that either type 1 or type 2 is more significant or more important. For me, both are the same. So either you find type 1 or type 2, both are giving the same significance that this is Willen syndrome biphasic or deep T-wave inversion. Here you can see V2, V3. There is T-wave inversion, deep T-wave inversion, V2 and V3. Here you can find that there is around 99% occlusion and after stenting. Second is De Winter syndrome. This was first identified in 2008 by De Winter and Willen also, who found that in 30 of their 1,500 patients who had anterior MI, around 2% had this characteristic pattern. The De Winter waves is proposed STIMI equivalent, to say anterior STIMI, but without obvious ST elevation. So again, also it is indicating proximal LED occlusion and normal ECG, normal ST elevation may precede De Winter pattern. Cases have been reported that De Winter pattern evolved from and to classic anterior STIMI. So it will either happen before STIMI or following STIMI. You can see this ECG pattern. So what is this pattern? This, as we said, De Winter syndrome is acute sign of proximal LED occlusion. So De Winter is like the acute form of Willen also. You will have hyperacute rocking T wave, and there is upsloping ST depression and smaller wave. So there is ST depression, but it is going up, like upsloping. And T wave is not inverted, it is upright and hyperacute. So the diagnostic criteria also should be present in the V leads from V2, V3. Usually in all V leads, there is tall, big, symmetrical T waves, and upsloping ST depression. This indicates critical LAD occlusion and mandates early or immediate coronary angiography. So this is an example of the winter T waves. You can see here in the V leads, focus in V2, V3. However, it can be present in the whole V leads. There is upsloping ST depression here and hyperacute T waves in indicating the winter syndrome, which is acute LAD occlusion. Here you can see there is totally occluded LAD. Also, the apical segments and the echo is also hypokinetic or akinetic with this pattern of ST depression plus hyperacute T waves. You can see here also V4, V5 is more manifest here. And also here an advice, whenever you find a patient with severe chest pain or persistent chest pain, and the ECG is not diagnostic of STEMI, even if you don't know these syndromes, you have two or more options. First thing, you connect the ECG and keep doing serial ECG until you find something significant. Second thing, you request also cardiac troponin, but usually it will be late. So better you will take the decision based on clinical and ECG and don't wait for troponin if the ECG is not diagnostic. But sometimes you have to order like 0 and 1 hour or 0 or 2 hours, 0 or 3 hour troponin. However, if you have bedside echocardiography, this also will be very helpful. So here, echocardiography also showed that there is wall motion abnormality in the apical segments. This also will support the decision that this ECG, ischemic ECGs are new and is mandatory for immediate angiography. Third pattern is ST elevation in AVR. And actually AVR is the forgotten leads because it is not going with certain territory. We have inferior territory, we have lateral, we have septal, and we have anterior, but AVR is like the maestro of all of this. So ST elevation in AVR with or without minor ST elevation in V1 with inferolateral ST depression, we can call it also in most leads. Inferolateral is an independent marker of acute left main stem occlusion. So left main is the main supply for the left of the left system and the main supply of the heart. Same also applies for AVR. So AVR is the maestro of the 12 leads. So the in-hospital mortality rates are very high, up to 94%, regardless of the method of management. Sometimes difficult to identify this patient because the predominant clinical symptom may be catastrophic, but not predominantly chest pain. So the problem here that this pattern is either present in a very stable patient or very sick patient. Sometimes it will be found accidentally, but in most cases you will have dramatic clinical scenario like pulmonary edema, shock, arrhythmia, respiratory failure requiring mechanical support, or post-arrest pattern in after rest. So the diagnostic criteria is ST elevation AVR more than 1 millimeter and ST elevation in AVR more than V1. This indicates left main. Widespread horizontal ST depression and most prominent in inferolateral leads, but also V1, V2, or V4 to V6. So what is the differential diagnosis here? ST elevation in AVR is not entirely specific for left main coronary occlusion. It may also be seen in proximal LAD. So maybe you will find left main free, but proximal LAD is also occluded. Sometimes it is seen in patients with multi-vessel disease and sometimes with diffuse subendocardial ischemia, like in shocked patient or severely hypoxic patient due to oxygen supply demand mismatch. Can it predict the anatomy in the context of widespread ST depression and symptoms of myocardial ischemia, which is important here? This patient has to have symptoms of ischemia. If there is ST elevation in AVR more than 1 millimeter, this indicates either proximal LAD or left main coronary occlusion or severe triple vessel disease. If the AVR is more than V1, this indicates left main or proximal LAD. If AVR is more than 1 millimeter, this indicates the patient mostly will need CABG. And the absence of ST elevation in AVR almost entirely excludes significant left main lesion. Here you can see this is the AVR, the maestro of the 12 leads. There is ST elevation AVR, and there is what we call it in most leads. There is ST depression here in lead 2 and AVF. You can find also V3, V4, V5. So ST elevation here and universal or most leads there is ST depression. This is a sign of left main or proximal LAD or severe triple vessel disease, which indicates CABG. And here also there is subtle elevation in V1. So here also AVR is more than V1, which indicates more left main disease. So left main coronary artery occlusion, AVR, ST elevation more than 1 millimeter, and ST elevation in AVR is more than in V1. Here you can see AVR, here you can see V1, here ST elevation more than V1. This is the left main. You can see it is coming direct from the aorta, then giving L6 and LAD. This is the main supply of the whole heart. So if you close this one, it is inevitably fatal if not tackled very early. Now we'll go to new or presumed new left bundle branch block. New or presumably new left bundle branch block has been considered a STEMI equivalent till AHA guidelines 2013. New left bundle branch block should not be considered diagnostic of acute MI in isolation. Although only a minority of patients with acute MI have left bundle branch block, their mortality is often significantly higher than that of other patients with acute myocardial infarction. So this is a classic left bundle branch block. This is lead 1. You can see positive waves, and in V1 it is negative. So left bundle branch block, you will have QRS complex above 120 millimeter or 3 small squares, large R wave in V1 and negative wave in V1. So lead 1 large R wave, and here V1 negative wave. This is the classic left bundle branch block. If the QRS complex is less than 120, this is not a left bundle, but you can call it interventricular conduction delay or incomplete left bundle branch block. So chest pain plus left bundle branch block. If the patient presented with acute chest pain with left bundle branch block, this can manifest in any of the following ways. First and the commonest, left bundle but no pre-existing ECG. Second, left bundle but the previous ECG did not show left bundle. So this means it is new. So you have ECG to compare and it is new. And here also another advice that always look for the patient old ECGs or previous ECGs. Whenever you can do so, get the old file, get the patient medical records, and try to check the previous ECGs. These are very helpful in the acute scenario and in decision making. In case you cannot get the ECG, the old ECGs, even if you have a patient, some of the patient will keep one copy in his wallet or in his mobile phone. If you don't have this option, then you can do serial ECG, because if you find the changes from 0 hour or 1 hour or 2 hour in your ECGs, this also is very helpful in making a decision regarding final intervention or thrombolysis. And if you got an old file with which the ECG showing normal ECG, then now the patient is presenting left bundle, so you know this left bundle is new. Third thing, left bundle and the patient is known to have left bundle in old ECG. So here, nothing regarding ECG. So you find left bundle, but it is old. So you will not base your decision based on ECG. Now you will omit left bundle from the equation, and you will focus on the patient's chest pain and cardiac enzymes and echo and hemodynamic status. So when to consider primary PCI, you should consider emergent or primary PCI for left bundle in three situations. First, if the patient is unstable, like hypotension, pulmonary edema, or electrical instability. Second, if you have Sagarbosa criteria satisfied more than 3 points. Third is the modified Sagarbosa criteria. So if the patient is unstable or Sagarbosa criteria fulfilled. So what are the Sagarbosa criteria? Sagarbosa criteria are invented by Elena Sagarbosa to identify patients who have STEMI with left bundle or best-resp, because it is difficult to know whether this patient is having ST elevation or not. So they invented this criteria and validated and discovered that there is 95% sensitivity and specificity for this criteria regarding presence of STEMI in the setting of left bundle or best-resp. It is not for right bundle, only for left bundle or best-resp. Because right bundle will not mask the ST elevation, and we will see it soon that right bundle can show ST elevation regularly. However, left bundle will not show the classic ST elevation. So what are these criteria? First, let's go back to the left bundle. In left bundle or classic left bundle, there is a rule of appropriate discordance. What is the rule of appropriate discordance? Rule of appropriate discordance means when you have QRS up, you will have the ST down. When you have the QRS down, you will have the ST up. This is the rule in left bundle. So whenever the QRS looking down, ST will look up. Whenever the QRS look up, ST will look down. This is the classic left bundle. So what is the Sagarbosa criteria? Here, there is normal left bundle. QRS is looking up, ST is looking down. But in ischemic left bundle, Sagarbosa criteria says that this elevation by any degree is considered STEMI. Again, if you have the QRS complex is down, ST should be up. This is a normal left bundle. Ischemic left bundle, QRS is down, and also ST segment is down. This is the second criteria, and is also very sensitive and specific. There is a third criteria, which is not that important as the previous two, but also has to be mentioned. Here you have QRS complex is down, ST segment is up, and ischemic left bundle QRS is down, but the ST is more exaggerated than normal. So it is like exaggeration of the normal. That's why it is not that sensitive or specific, but these are very sensitive and specific. So here, left bundle, QRS down, ST up, QRS up, ST down. And here, you will find that QRS complex is up. If the ST is elevated by any degree, this is STEMI. Again, QRS is down, ST segment is down by any degree, this is STEMI. And there is third criteria or modified. If the ST to S ratio is more than 25 in elite, also this is STEMI. So this is a classic left bundle. QRS is up, ST down, QRS up, ST down, QRS down, ST up. This is classic. Then what will happen here? You can see here, QRS is up, ST is up, QRS is up, ST up. This means STEMI. Okay. Here, again, this is Sagarbosa criteria, ST elevation, and here ST depression, and here more than 25%. So new left bundle or left bundle with Sagarbosa criteria, or unknown left bundle plus hemodynamically unstable patient. So back to conclusion. So suspected acute myocardial infarction with left bundle. If the patient is hemodynamically unstable or in acute heart failure with left bundle in the ECG, then you are done. This is for primary PCI. You will consider it or as presumed new LBB because of the presentation. If not, you will try to apply Sagarbosa criteria. If Sagarbosa criteria positive, you are done also. This is STEMI, activate cath lab. If not, and the patient still symptomatic, you will do serial ECG, check troponin, bedside echo. If it is abnormal, you will go for coronary angio, not necessarily immediate, but you will go for coronary angio because it is supported by this data. If everything is normal, then you will consider non-invasive evaluation like CT, stress myoview, or stress echo. Here, this is right bundle branch block. You can see the rabbit ears here. This is the classic right bundle. And you can see here that right bundle will not prevent STEMI from showing. So here you have right bundle, but still you can see the ST elevation here. So in right bundle, you don't need Sagarbosa criteria because if there is STEMI, it will show. If there is STEMI inferior, it will show. If there is in the anterior, it will show. So right bundle, you don't worry about Sagarbosa, only left bundle. Isolated posterior myocardial infarction. Around 4 to 7% of STEMIs present as isolated posterior myocardial infarction. In spite of relatively small mass necrosis, the clinical consequences of posterior MIs are often serious and disproportionate. This can be explained by the mitral regurg, which is present in around 70% of isolated posterior MI and usually moderate or severe and causing pulmonary edema, which will add more. This ECG find should be treated as STEMI. So if you have posterior MI in the setting of inferior, it is easy because you will activate the cath lab. Even if you don't know there is posterior, you will detect inferior and it is solved. The problem is that if the surface ECG doesn't show any ST elevation and only shows posterior MI, it can easily be missed. And usually the scenario will be that patient is having persistent chest pain or some troponin elevation, but the ECG is not showing any ST elevation, so it can be missed very easily. We advise usually if the surface ECG is not diagnostic and the patient is having chest pain, please do right leads and the posterior leads and carefully look at the posterior and the right leads because you can only find the posterior ST elevation in the posterior leads. Sometimes you cannot see in the anterior leads. Sometimes it will show like depression in the septal leads with positive R, sometimes not, only at the posterior leads. The clue here is the patient symptomatic and the ECG is non-diagnostic. Go for serial ECG, go for right and the posterior leads, go for echo bedside and troponin. Here you can see one example. If you look at V1 at lead 1, 2, 3, AVL, AVF, nothing. So 1 and AVL, there is no elevation. 2, 3, AVF, no elevation. If you look at V1, V2, V3, 4, 5, 6, there is no ST elevation. Some will label this as non-STEMI. This is not non-STEMI actually. This is STEMI, but it is posterior and it is isolated posterior. Okay. So even the machine will label it as abnormal ECG, of course, but some people will call it non-STEMI. If you know that there is something called posterior STEMI, you will diagnose this as posterior STEMI and you will activate cath lab for this as posterior STEMI. This one, if you did posterior leads, you will find ST elevation only in the posterior leads, and here is the trick. And it represents around 4 to 7% of patients with MI. So if you are seeing per month like 100 cases of MI, you may find like 5 or 6 cases with this pattern. Either it will be missed or labeled as non-STEMI, or sometimes will not be diagnosed correctly. So here, posterior wall myocardial infarction often accompany inferior or lateral. But the problem, if it is coming isolated, it can be missed very easily. Posterior extension of inferior or lateral implies large area of infarction, difficult to pick up on ECG. So the changes are in V1 to V3, horizontal ST depression, and the tall, broad R wave. So ST depression together with positive or tall R waves, upright T waves also. So it is like mirror image of the posterior leads. Here the posterior lead V7, V8, V9, and these are extra leads that we put to check for posterior MI. So you will get limb leads the same, but you will put V3, 4, 5, you will put it, or V5, V6, you will put in this pattern at the back to show the posterior leads. And here, any degree of elevation is diagnostic. So even if half square, it is diagnostic. Any degree of elevation in the posterior or right leads is diagnostic. The other trick that these changes are never old. So you cannot find old posterior elevation or old RV elevation. Actually, posterior ST elevation or right leads ST elevation will disappear within 12 to 24 hours in most patients. So after 24 hours, these changes will disappear also from the posterior or right. So it is necessary to be detected as early as possible. Here you can see there is no ST elevation. We said 1 AVL, no elevation, 2, 3 AVF, no elevation. Here also from V1 to V6, no ST elevation. So this patient having STIMI without ST elevation. Why? Because of the posterior or isolated posterior ST elevation. Here when they did ECG posterior leads, there is ST elevation in V7, V8, and V9 with very subtle degree, and you can find that L6 is occluded completely. Here again, ST depression, T wave is positive and R wave is tall, indicating posterior STIMI isolated because there is no other lateral or inferior here. You confirm by posterior leads. Finally, we'll summarize the take-home messages from this lecture. First, treat the patient, not the ECG. So never look at the ECG without knowing data about the patient or seeing the patient yourself. Whatever decision you will give on an ECG will not be correct without seeing the patient or knowing his clinical data. Because even patient with STIMI can sometimes present very early with normal ECG, and the ST elevation will show only on serial ECG. Sometimes also a patient in cardiogenic shock, his ECG looks normal or there is non-specific changes, but based on the scenario, he's having severe chest pain, then he became shocked. You will activate cath lab based on the clinical, not the ECG. So always treat the patient, not the ECG. Also, you can have some ST elevation in ECG, but the patient is young and he doesn't have any cardiac history and he's asymptomatic, and it will turn out that ECG changes here are due to early revascularization or some arrhythmic syndrome like Brugada syndrome, sometimes electrolyte abnormalities. So ST elevation can be with normal patient and the reverse. ECG can be normal in a patient presenting with an early STIMI. Second is that one ECG begets another. Serial ECGs are very helpful. As we said earlier, if the patient is symptomatic and first ECG is not diagnostic, it is very important to get serial ECGs. Better safe than sorry. If you have doubt, admit the patient, do serial ECGs and troponin to rule out acute coronary syndrome, because if you did not do so, you are going to miss many of the patients who do not present classically, because there is nothing is 100% in medicine. So some people will come with maybe some epigastric discomfort only, will come with dizziness, diabetics, elderly, and the female usually have a typical presentation. So be careful about this patient. Time is myocardium. Do not postpone reperfusion therapy once diagnosis is confirmed. So once you are sure that you are dealing with a STEMI, either you will give thrombolytic therapy after ruling out contraindication, or you will activate cath lab and go immediately for primary PCI. Life is not easy. Common things occur commonly, but rare are still there. So every day you are seeing the classic presentation, but at some point you will find very abnormal ECG, very abnormal presentation. From these cases, we continue to learn, and science also will continue to grow. So better when you face something like this, you get second opinion, you admit the patient until you are sure that there is no acute coronary syndrome. So as we said, nothing is 100% in medicine, but one life saved worth the hard working. So some people will tell how many ECGs we are going to do, 5 or 10 or how much. Actually, there is no specific number. You will just, if you are doing serial ECG, either the patient pain will be relieved and the ECG is not showing anything. So now the patient is safe, or the ECG will show some dynamic changes, or the patient pain will be persistent and the ECG is still normal. So you go to your diagnosis also, and you have to proceed further for angiography or thrombolysis if indicated. When you don't know, ask. When you are wondering if you should ask, ask. And if in doubt, always get a second opinion. Sometimes in a stressful situation, you can miss small changes in the ECG. Sometimes you can also get confused regarding the rhythm, AFib or STVT or something. But sometimes if your senior, you send to him the ECG, he can give you also an idea, because sometimes the patient is in pain, he is sweaty or unstable. Sometimes you get confused, or you feel distressed yourself. So at that time, also getting a second opinion is good, because he may see something that you don't know. He may recognize certain syndrome, which is STEMI equivalent, you don't know. So it is not. It is always a good idea, if you don't know or if you have doubts, you ask and get solid information from your colleagues or senior. And here also, ruling out cardiac ischemia is much more difficult than ruling it in, and will usually need more time and work up to prove. So suppose that patient presented to ER with, he has risk factors, he is 60 years, diabetic, hypertensive, dyslipidemic, and he is having typical anginal chest pain. Then you took one ECG, is showing anterior ST elevation. So this is a bread and butter or clear diagnosis. But in many scenarios, you will find patient is coming with only one risk factor, like smoking, and he is middle age, he's not 60, he's like 40 years, and ECG is not showing ST elevation, is showing only some T-wave inversion. Maybe his pain is not that typical, he is having some feature of typical pain or not. So this case for us, it is more difficult than STEMI, because the making the diagnosis here challenging. You can say he has no acute coronary syndrome, then he may die after discharge. And on the other way, you can say, yes, he's having acute coronary syndrome, and unnecessarily you will do coronary angio. Maybe it will be normal and you will have some complication of the angio itself. So these cases are challenging, and the clearing patient is more difficult than diagnosing ischemia. So this also I want to emphasize that ruling out cardiac ischemia is much more difficult for us than ruling it in. Finally, winter is the summer or the season of MI, arrhythmias, and cardiac mortality worldwide. And wish you all that you are safe and happy in this 2020. And we hope also that this COVID epidemic will be over and we return back to our normal life. Looking forward to see you, all of you, and thank you for your attention, and thank you so much.
Thank you, sir. Thank you so much for the wonderful talk. Thank you so much for that. It was very, very elaborating and very well done, sir. And now we'll move on to the question answer. For that, I would request all the doctors in the live session page. Doctors, there is a chat option. Post your queries here. There you can write down your queries. You can write down anything from your end, and then we'll take all the queries. So we have some queries, two queries like what is the shark, SHARK, shark fin in ECG? If you could highlight your comments, sir.
Shark fin?
Shark fin, FIN. I will also post the query in the chat section. That will be easier, sir. Yes, here is the query, sir.
Yeah, shark fin also is a very dangerous sign in ECG and usually also is associated with very dramatic clinical scenario. And it is not specific for certain artery occlusion, as we said here, but sometimes also is not cardiac presentation. I'm going to show here one case. For the sake of time, I did not mention, but very interesting actually. You can see here.
Thank you, sir. Thank you so much. Another query. Yeah.
I am going to show here one.
Sure, sir.
One ECG with the example of this change. So you can see here there is tombstone. Some will call it shark fin also. Here you can see. Okay, here and the most ECG. This is actually a case that has been presented in the American Journal of Medicine 2020. This is a 25-year-old female with ibuprofen toxicity. You can see here how the ECG look. It's very horrible. Tombstone, some will call it shark fin. And actually, it was not ischemic. They thought it is STEMI, but after angio, it turned out to be not STEMI, and